Hi, my name is Chris. Thank you for tuning in. Today I'm going to be talking about epilepsy in pregnancy. So to start off my brief facts right now, the first one is anti-epileptic drugs can decrease the efficacy of oral contraceptive pills as well as Nexplanons. 80% of pregnancies in epilepsy patients might be unplanned, so it's important to start taking folate as soon as possible, which has been linked to increased cognitive outcomes. Overall, the risks that you're going to experience during pregnancy might be preeclampsia, which is a high blood pressure disorder, preterm birth, spontaneous abortion. AED usage during pregnancy, monotherapy is ideal, and you should not be using valproate, phenobarbital, or phenytoin. That being said though, 90% of pregnancies with patients with epilepsy are completely straightforward and normal. Cesarean section is only indicated for obstetric reasons. 70% of patients will have seizure-free experience throughout pregnancy, and during the postpartum period, there might be an increased risk for anxiety or depression, so it's important to make sure that your provider is aware about that. And for breastfeeding, it has also been shown that really there's no adverse outcomes from any AEDs in a long-term effect. Hi, my name is Chris, and I'm going to be talking about epilepsy and pregnancy. Briefly, from a population standpoint, 1.5 million females of childbearing age currently have epilepsy, and that results in 24,000 deliveries each year from patients who have epilepsy. Epilepsy is defined as greater than 2 seizures over 24 hours apart, or positive EEG findings. Seizures in general are an imbalance of your excitation and inhibition of neurons in your brain. Estrogen causes seizures and progesterone protects seizures, kind of more or less. Catamenial seizures are seizures associated with menses, more likely to happen 3 days before or after your menses or during the middle of your cycle. In regards to contraception, really only 25% of patients who have epilepsy are on any type of OCP or contraception, and those are sometimes suboptimal because they can be broken down by your anti-epileptic drugs. Ideally, new generation IUDs or barrier methods are going to be preferred. Moving on from contraception and into the pregnancy planning category, patients who have epilepsy have equal fertility, but it also has been shown that they are more likely to have ovulatory disorders. Regardless though, 80% are going to usually have unplanned pregnancies, so it is important to start folate or B9 as soon as possible, even if you're on contraception, because it's been shown that there's improved cognitive outcomes for patients who are on AEDs who are taking folate. The general recommendation is 0.4 milligram for regular patients throughout pregnancy. 1 milligram is for any AED, 4 milligrams for Tegretol or valproate, and you shouldn't really be on valproate or phenobarbital or phenytoin. It is important to talk with your doctors in regards to wanting to become pregnant, your neurologist as well as your OBGYN, because your neurologist is going to be important in making sure that you're on the appropriate therapy. Ideally, monotherapy is preferred. You should maybe be trialing to reduce the meds, so you're either poly to monotherapy or trialing off your medications in general. If you don't have seizures between 9 months and 1 year prior to conception, there is an increased likelihood that you're going to have a seizure-free pregnancy. Usually there's 70% percentage that you're going to have seizure-free pregnancy, so it's like pretty good, but it's still important to talk to your doctors to make sure that that's okay. In regards to anti-epileptic drugs, there are a ton of them, and I'm going to be showing a nice little diagram right here so you can appreciate them. There was this thing called the URAP, which is like the Europe and International Regulatory AED in Pregnancy, and what it showed was that 66% of pregnancies are seizure-free and 73% are seizure-free if they previously were like a generalized genetic seizure. 60% only were seizure-free if they had focal seizures. In regards to congenital malformations, and I'm going to be looking at this graph as well, for baseline you have 1 to 3% risk for congenital malformation, regardless of whatever you have. If you're taking valproate, as you can see on this graph, you have like a really increased risk of having major congenital malformations. Ideally, the best medications for you to take are lamotrigine and levetiracetam. These are the best because they have consistently shown to have the best track record for low likelihood for fetal malformations. Now, in regards to AEDs during pregnancy as well, there's important physiologic changes that happen within the pregnant patient. And there are 4 main things. The first one is nausea and vomiting. So if you're in the first trimester, you already know what I'm talking about. You have increased blood volume and decreased albumin. Albumin is like a little shuttle that brings around anti-epileptic drugs. So you have decreased amount of that and you have increased blood volume. So it kind of reduces the ability for you have that nice serum level, as well as you have increased renal blood flow. So actually more of that drug is getting pumped out and cleared through your kidneys. And the last thing is you also have increased liver metabolism, which is one of the ways that some of the medications are actually like deconstructed and broken down. So moving on from pregnancy planning to actual pregnancy, congratulations. There was a recent NEJM paper, December 2020, that pretty much showed that there is no increased risk for seizure frequency throughout pregnancy, and there is no pre-pregnancy to pregnancy increased risk of seizures as well. There's been a lot of research about like these variabilities, but I'm going to be putting my money onto this paper. This is a Dr. Pennell paper from Brigham and Women's, and this is the paper that I'm going to be going off of, saying that there really is no increased risk for seizures during pregnancy. The one thing they did note was that you're going to have an increased likelihood for medication changes. The risks during pregnancy that you can experience if you have epilepsy are increased risk for preeclampsia, which is a blood pressure disorder during pregnancy. You're going to have an increased risk for spontaneous abortion, and you're also going to have an increased risk for preterm birth. What you're not going to have an increased risk for is gestational hypertension, hemorrhage, infection, or stillbirth. And there was I guess some of the data did show that there was increased risk for C-section, but part of that was muddied by the fact that was elective. So it's kind of hard to say that as well. In the US, 6 per 100,000 are maternal mortality. That's like what the rate is. And that can increase in some studies to 80 over 100,000. So there's a slight increased risk if you have epilepsy. So it's important to start with your OBGYN, neurologist, and MFM to make sure everything is okay. And how do we manage an epileptic patient during pregnancy? So working with neurology and OBGYN is first and foremost. It also recommended for you to do screening for chromosomal abnormalities because epilepsy is not really associated with that, so it's still a recommendation for that. You should be measuring your serum levels, or your doctor should, every 1 month, so Q4 weeks, as well as a one time at 6 weeks postpartum. And that's because a lot of those serum levels can change throughout pregnancy from all of those physiologic changes that I mentioned a little bit earlier. You should also be getting an ultrasound around 17 to 20 weeks, and this is to look for neural tube defects, NTDs. You can also plus minus do a serum alpha fetoprotein at 16 weeks, which is another way that you can indicate possibly a neural tube defect. But there's also, like, if you have twins or misdating or gastrointestinal stuff, you can have also modified AFP levels. So it's also very important on that. If your first seizure is in pregnancy, we're going to have to rule out eclampsia, and we're going to rule out central venous thrombosis. If a seizure is started, however, we're going to be giving you IV lorazepam, Ativan. 1 milligram in general usually is sufficient, but if you have a generalized tonic-clonic, then we're going to be giving you 2 milligrams. Magnesium is not beneficial to treat those seizures. That really is only if you have eclampsia, which is a high blood pressure disorder. And AEDs are most commonly missed during labor, so it's important to make sure that you're maintaining your regimen during that time period. Sleep deprivation during the labor process as well can be associated with increased seizure risk. With that being said, it has been recommended by some groups to get early neuraxial block, like an epidural early on in pregnancy, like early on in the labor, so that you're able to sleep and rest during your first phase of labor. In regards to the postpartum assessment, in regards to epilepsy, there is an increased risk for depression and anxiety, and these patients are less likely to receive meds. And this is compared to patients who have hypertension or asthma or renal disease or cardiac dysfunction. So it's important that if you're feeling symptoms of down, depressed, or hopelessness or anxiety, talk to your doctor and make sure that you're on the appropriate medications. AED dosages should be dropped down because they usually are an increase during pregnancy, so they should actually be dropped down in the postpartum period. And like drugs like freaking like lamotrigine should be dropped in like 10 days after, because there's like a huge drop in that. And then finally, last thing is breastfeeding. And breastfeeding, really, we should be encouraging breastfeeding, and like all the literature says that you should be encouraging breastfeeding for patients who are taking anti-epileptic drugs. There are, of course, fat-soluble anti-epileptic drugs, and those can be found in the breast milk, and that breast milk can be passed to baby. So barbiturates, benzodiazepines, lamotrigines, zonisamide, as well as ethosuximide can also have high levels within the infant. And sometimes, especially with like benzodiazepines or phenobarbital, they have increased risk for irritability or infant sedation. So making sure that you're aware of that as well. But still, it's recommended. And longitudinally, it's been shown that really AEDs do not have any negative ability on the cognitive development of babies when looked at 6 months and 18 months. And in fact, patients who breastfed for longer had increased cognitive outcomes at those time points as well. And then looking at the 6-year analysis of patients who were on AEDs and breastfed, there was no change in IQ score at 6 years of age. So that is a brief understanding of epilepsy and pregnancy. I hope you enjoyed it, and I'll see you for the next video.